introduce the next speaker. The next speaker is Dr. David L. Dawson from the University of California, Davis. He is a professor in the Department of Surgery, and he's going to talk to you about lesion crossing access and specialty wires. Some people would call this a Coles to Newcastle talk because it's addressing a group of experienced vascular specialists. But the group, as I told you this morning, is somewhat of a heterogeneous group. We have surgeons, radiologists, cardiologists, and others here, and not everybody does everything. I'm going to talk a little bit from the perspective of someone whose practice includes a large volume of critical limb ischemia work, and talk about a few things that we've learned along the way, a few things that we've adopted, and not get into any attempt to compare some of these different apples that are out there, but to give you a little bit of an overview of the types of devices and products and techniques that are needed for successful interventions for critical limb ischemia. Talk about vascular access, talk a little bit about interventional sheaths, guide wires, and crossing devices dealing with vessel occlusions. I do have some consultant and research support relationships, but none that are directly related to the topic today. First, let's talk about access. First of all, any procedure, any intervention starts with vascular access, and the consequences of an imprecise access are usually nil. Femoral artery thrombosis can occur, pseudoaneurysms or groin hematomas may happen, and occasionally there's a large groin or retroperitoneal hematoma. So usually it's not a big deal, but sometimes it can be a big deal. So what do you do to minimize the morbidity of the approach and to maximize the success of the procedure? Well, one of the things that we've adopted for many of the procedures in our lab, all of the ones that I do, is ultrasound-guided access. Safe vascular access can be achieved without imaging, and that's the way I learned it, but with imaging, you can reduce the risk of vascular injury because you can more precisely enter the vessel at an area that's not diseased. You can recognize the variant anatomy, you can find that high origin of a profundifemoral artery, you can see where the graft origin is. Whatever the situation may be, you'll have that situational awareness. And you can obtain access in pulseless arteries, which is often the challenge in treating patients who have lower extremity peripheral artery disease. Ultrasound-guided access reduces the risk of hematoma or vessel injury because if you get in accurately and precisely the first time and you don't get any hematoma, you're more likely to get good primary hemostasis. It improves the results with vessel closure. If you're using a suture-mediated device and the needles have to pass through the vessel wall, if they pass through a relatively undiseased segment of vessel wall, you'll be more successful. If you use a device off-label for pre-close, for large vessel closure, such as we do for percutaneous aortic aneurysm repair, ultrasound-guided access allows precise placement of those closing sutures. And you can avoid damage to important and expensive adjacent structures. The technique is to sheath a transducer in a sterile sheath with gel in it. I tend to image the vessel in the longitudinal plane. I'll find out how far north or south I want that needle to enter the vessel. I'll be able to visualize the inguinal ligament, visualize the profunda origin, visualize plaque in the common femoral artery segment. The other technique is to infiltrate anesthesia under ultrasound guidance because you can put the anesthetic right in that periarterial plane. I watch some people infiltrate and they'll put a large volume of anesthetic into the subcutaneous tissue where the nerves don't live. And the patient then says, ouch, when the sheath goes into the artery where the nerves do live. So it's actually a nice technique for more precise local anesthesia. Introduce the needle in that longitudinal plane and then turn transverse to then do the fine-tuning to center the needle to puncture the vessel in the center line. And then the ultrasound can confirm the intraluminal placement of the guide wire. I like to use the micropuncture technique with a 5 or 4 French micropuncture catheter, a 21 gauge thin wall needle. You can use an echogenic needle or an echotip needle to help improve visualization with ultrasound. And the micropuncture technique is especially useful when you're doing brachial access or superficial vein access. It is less effective when accessing through dense scar because the 18,000 guide wire that comes with the set doesn't have the stiffness to support passage through densely scarred tissue, so sometimes a larger needle and 035 system is useful. By doing the setup on a routine basis, you don't have to worry about answering the question, do I want to use ultrasound this time? It's a real hassle if you start and have trouble and then say, okay, now I'm going to use the ultrasound. If you always have it, it's always set up, it doesn't add any time to the procedure, and you and your trainees gain the experience of getting that mental picture of what the vessels look like with ultrasound, and it goes quite quickly. In general, it's a freehand technique. The non-dominant hand will hold that sheath transducer. The dominant hand will hold the needle and advance it, and then the needle is stabilized once the vessel is entered and the tip is centered. Now, there are other devices that some people use, and the needle guides that are available for some systems helps to keep a needle in a scan plane. I think it's a little harder to use, quite frankly, than a freehand technique once you get that 3D picture in your brain. And there's some other products coming out, including a system from Ultrasonics, which adds a 3D navigation system to localizing a needle tip in space and giving you essentially a head-up display to show the trajectory of the needle before it enters the vessel. These may be useful adjuncts, I think, to teaching people that 3D spatial recognition, but once you learn it, I think it's a very easy technique. Regarding access, we'll use contralateral access for treating the distal external iliac artery, the superficial femoral artery, at least in the proximal portion of the vessel, for most tibial cases. But there can be some challenges. First of all, steeply angled aortic bifurcation may be difficult to track devices over if there's a lot of tortuosity in the iliac segments, or if there's a significant amount of plaque, especially calcific plaque, that can increase the friction and the difficulty passing devices. There are a few new tools, including wires that have a stiffer back end, a more floppy front end, like the Terumo glide wire, the Advantage, that you can get that more floppy segment to track and then push that stiffer segment over, and it allows you the support that you need to cross with a support catheter that you can then exchange for a stiffer wire that you can subsequently use for placement of the sheath. In general, I think it's tracking after initial crossing is easiest with a hydrophilic or non-rigid catheter, but the disadvantage is those sometimes will flip up into the aorta. The stiffer the guide wire, the easier it is to do sequential exchanges, and the easier it is, I think, to track the sheaths into a more distal position. And there's really nothing that feels better than having a nice, safe access across a challenging segment. If you have a stiff wire in place and a distal sheath placement, you're able to handle most problems that then occur. Sometimes a coaxial sheath and catheter system may be required to build up support. And it helps if the sheath has a hydrophilic coating. And sometimes it helps to use lower profile systems. If you're doing tibial intervention and planning only angioplasty, there are long 90 and 110 centimeter tibial interventional sheaths that are available as small as 4 French. There are some alternatives to the contralateral femoral approach. The brachial approach allows you essentially an antegrade access to the lower extremity arteries, or antegrade femoral approach when the target vessel is in the distal portion of the superficial femoral or more distal in the limb. Other alternatives for crossing the aortic bifurcation include stiffer devices to cross, including a steerable guide catheter such as the Morph, and there's some other directable or catheter navigation systems that may come into play in the future. There are a variety of sheaths that are available. The sheaths that we'll typically use for contralateral access are flexible and trackable. Some people like a shaped sheath. For the most part, the older Balkan type shaped crossing sheaths I don't think are really necessary, because over a stiff guide wire you can track most straight sheaths. They can vary in size as small as 4 French. 6 French is more standard if there's an anticipation that there may be an intervention on the femoral or iliac artery, and a stent may be used. But a larger sheath may be required if atherectomy, covered stents are going to be used, or other complex intervention is anticipated. Sheath positioning, if you have the tip as distal as possible, it's useful because that gives you the best ability to do imaging and get contrast into the vessel with the least amount of contrast, and gives you the best support. Some rules of thumb: 45 centimeter sheaths positioned close to the common femoral artery, just proximal or distal to the common femoral artery, depending on the patient's anatomy, and a 90 centimeter sheath, the kind that you might be using for a carotid intervention. If you're using it for infrainguinal intervention, a 90 centimeter sheath will get you approximately to the joint line in the popliteal artery. It's useful, I think, to consider angioplasty or stenting of proximal occlusive lesions in the iliac or femoral arteries to avoid having a sheath occluding the vessel. It's helpful to have antegrade flow to prevent thrombotic complications and to get good contrast visualization. It's also important to anticoagulate when large sheaths are in small vessels. But you always have to be careful that the more proximally placed stents are not disrupted by the passage of the devices that you subsequently use. Regarding some comments about guide wires, there are a variety, of course, of guide wire sizes, and you trade support for torqueability or profile. Stiff, non-hydrophilic guide wires, I think, are the easiest to use for most interventions because they have the least tendency to move in the vessels, but they may not be the best or safest technique to get there. The smaller wires allow you to use low-profile devices, atherectomy devices, reentry devices, and some small caliber stents. There are a variety of things that you need to know about guide wires. For the cardiologists in the room, the interventional cardiologists are very adept at using 014 guide wires and have a whole family of guide wires that will be used for different techniques and crossing coronary occlusions. And some of these translate directly into the peripheral circulation, some of them don't. The peripheral occlusions are longer. They go through a more tortuous segment sometimes, and some of the features of the wire that some people are used to being able to feel the tip behavior a little bit harder to translate into peripheral interventions. There are numerous choices: the mandrel selective guide wires, hydrophilic guide wires, coiled stainless steel guide wires. And if you look in endovascular today, which has a nice compilation of a variety of manufacturers' products, you'll see about a dozen pages of content. And so what at best I think one can do is make some general recommendations that each interventionalist become familiar with the families of wire types that might be used for a different type of case, and then become familiar with a few specific wires that can be used on most cases. What's new? There are wires that are specifically designed for specialized peripheral applications. So it's not just a wire that was designed for a different application now translated into a tibial setting. Coronary wires aren't perfect, don't translate perfectly into a tibial application. Some of the tibial crossing wires may vary in length, more supportive shaft and tip designs that allow the tip to have the force more focused and variable tip loading. Support catheters can include standard selective catheters or specialized catheters. The tip, positioning the tip of the catheter near the wire tip in the field of view is typically useful. This allows for wire exchanges. Specialized crossing catheters may have a tapered tip or thin wall for easier crossing, and a radiopaque tip for easier visualization. Angle tip may be useful for steering, which is helpful for anterior tibial interventions. And some operators prefer straight wires and an angled catheter to steer them. I mentioned that tactile feedback may be lost when a wire traverses a tortuous course. It's also lost when the catheter lumen internal diameter closely approximates the wire outer diameter or a wire is traversing an occlusion. What's very useful in lower extremity cases is to visualize the behavior of the tip as a primary indicator of what's happening. If there is deflection of the tip as the tip is catching on the vessel wall or on plaque, that may indicate that that's not the actual course that you wish to traverse. Wire bending proximal to tip indicates that there's some loading on the wire, or loss of one-to-one movement, either forward and back or torquing. A variety of devices have been marketed for helping with crossing occlusions. One of the earlier ones was a mechanical device, the front runner. Tornus catheter is a device used for coronary occlusions, which is a little bit like a corkscrew, a catheter that will physically be able to push through the plaque Step-by-step laser crossing technique was one that was advocated and used by some. And a crosser catheter is a specialty catheter that goes over the wire that uses ultrasonic vibration, or it's a directed energy device, really. It's a little mini jackhammer. Newest one on the market is more of a mechanical crossing device, another screw-type technique to enter plaque and to have a coaxial system where 14 or 35 thousandths guide wire goes through the device. And there are a couple of reentry devices that can be used, ultrasound guided or image guided, to get a 14 thousandths wire from a subintimal space back into true lumen. Just a quick example of a patient with critical limb ischemia and diabetes who presented with an infection of the great toe requiring open amputation for control of the infection. He had no proximal occlusive disease. Femoral artery was fairly clear, but the anterior tibial was occluded, and distally the posterior tibial and perineal were occluded, reconstituted in the dorsalis pedis. This is a case where a wire could be maneuvered into the occluded anterior tibial artery, and here it's supported with a balloon catheter, but it couldn't cross the more distal portion of the vessel, and you can see here the tip has exited the vessel. Well, this is one where a reentry strategy doesn't work. It's too small. You can't really use an antegrade approach anymore, because once there's a hole like this, it's often difficult to get that back in the true lumen. And so in this situation, a more distal access with the dorsalis pedis puncture was done, and then the wire is snared in the popliteal artery, and a through-and-through access is attained. This allows balloon angioplasty of the occluded segment down into the dorsalis pedis with a long balloon and recanalization of the occlusion perfusion of the foot, which saved the transmetatarsal amputation. So this is just an example of a different crossing challenge, access challenge. I think there'll be a few other questions that might come up in the panel. But with that introduction and how to get there, I'd like to stop and then invite Krishna Roch-Singh up to talk about the next step. Well, now that we've gotten access, now that we've got a wire in place, maybe got a balloon in place, what do we do to keep the vessel open? Ask Dr. Singh, Roch-Singh, to talk about use of stents and femoral, popliteal, and tibial arteries. Thank you for coming.
Thank you for inviting me. It beats the last time we met each other. He doesn't recall pouring a... he does. I won't recant that. Well, what I'd like to do here in the 20 minutes I have is to challenge you. Now, I'm sure the last thing you want to be done to on a Monday at 5 o'clock after being on double diamonds all day is to be challenged. But I'm going to resist the temptation of regurgitating a bunch of, as Dr. Martin was reviewing, a bunch of level 2B data, non-randomized, retrospective, single-center trial data, which is unfortunately what we have a lot of. And so I'm really going to talk about use of stents in the lower extremity, and as part of that, really challenge the status quo. These are my conflicts. I don't believe any of them are relevant in the things I'm going to have to say to you. I will be discussing, of course, off-label devices in the periphery. Now, I just want to, again, recap. I want to discuss emerging data and its clinical relevance. And I think that's an important key to hammer home. And then to challenge the status quo by, in regarding the established effectiveness of those endpoints as they relate to what we call success. What is success when we start after we cross the wire and put in this stent? How do we measure success? And consider, I think, more appropriate patient-centric metrics for some of the stent trials that we are doing, because I think this is going to be a big deal, not just to the FDA, but for an organization called CMS, which is going to reimburse what we do. We have to give them what they want, which is more patient-centric information that is reasonable and necessary. So what has happened in the past 7 years, almost 10 years? We see what has evolved in our thought process based primarily on the TASC2 data. And recall that TASC is essentially expert opinion and consensus. It is not predicated on level 1 data. In the past 10 years, we've gone from TASC A back in 2000 to being still TASC A, but look at the lesion links. TASC B is now TASC A. Previously, task C is now task B, and previously, what was a task D is now a task B lesion. This, I think, reflects the progression of technique and technology in addressing some of the issues that confront us and dealing with some of our patients. But we have to ask, how was this data defined? We know that this is a statement right out of task, that low morbidity and mortality of the endovascular technique would suggest that angioplasty for a lesion up to 10 centimeters should be the choice. Now, I want to raise hands. How many people would tackle a 10 centimeter SFA with primary balloon angioplasty? I think that, oh, good, I'm glad. 1, 2. I just see 2. So I think what you're saying either I think what the non-responders would suggest to me, as these non-responders are saying, is that they believe that primary stenting now has become the default strategy. And I want to challenge you and ask, why do you think that? Why do you think that that is it? Because we do know that when it comes to the SFA, we have poor data. We have retrospective data that combine lesion lengths, stenoses and occlusions. We have mixed patients with claudication and CLI. We have patients where primary patency is defined by peak systolic ratios of 2, 2.4, 2.5, 3.0, and they're assessed at various time points. And so we understand that this is a gamish, and again, this is what we're dealing with, and how do we make sense of it? Well, about 5 years ago, Viva, my partner Dr. Laird, and I, and 8 of our partners went and we tried to elevate the clinical science. We knew that Resilient was going on, and it was a randomized trial of angioplasty and stenting. And we understood that that's such an expensive way to get things on label. And so we looked at, along with the FDA, literature looking at angioplasty, and developed a historical control performance goal for angioplasty. We also went to industry and we asked for their data that was part of randomized trials to get on label, which was something that had not been done in the SFA before. And we came up with, this is 33% now, this is 33% combined angioplasty. Patency at 12 months, 33% from balloon angioplasty. So those 2 people in the back who use balloon angioplasty, if they're following the data, they understand that the probability of restenosis at 12 months, as defined by duplex Doppler, in something that was adjudicated and peer-reviewed, is less than 40%. The FDA bought into this, and here's now what the unintended consequence. John, I don't know if you intended to do this, but it wasn't my intention, that all these trials now are using the performance goal, and we have 1, 2, 3, 4, 5, 6, 7. We have 7 trials that are either been completed, soon to be completed, or will be started. And I ask you, how many different nitinol stents do you need to have on your cath lab shelf? And are bare metal nitinol stents soon to be just a commodity? I can tell you in our lab, our administrators came to us and said, we want 2 stents on the shelf, because we believe there is no significant difference between them, and cost now is our bottom line. So we're going to have the government telling us, and now we're having hospital administrators telling us what we need to do. Jason is going to follow me. I'm not going to steal his thunder, but I just want to suggest to you that stenting in the SFA may soon undergo a game changer here with regards to Zilver PTX. But I wanted to, with relative to what my comments are, express 2 points. Look at this lesion length of 5 centimeters. 5 centimeters in a prospective randomized trial. Now, Dr. Martin wants to look at apples and oranges. These are real small apples and real small oranges that we're looking at when we're looking at this large prospective multi-million-dollar trial. And so I gotta say, you know, where's the beef? Why are these companies spending millions of dollars to go after 5 centimeter lesions with high technology? And so that's the type of stuff we need to be concerned about. I want to spend some time, I'm not going to regurgitate some of the other trials, because this trial, a randomized trial, done by a group of investigators under a physician IDE, I think reflects some of the issues that we have problems with. This is a study called the Vibrant trial. It was a randomization between the Gore-Viabon and the nitinol stents that were on label at that time in long lesions with long-term follow-up with core lab adjudication. Now, this is probably as good as it's going to get in the United States with physician IDE trials. Again, Gore-Viabon was approved, and most of these bare metal stents were not approved. It was not the desire to compare a specific off-label stent against the Gore-Viabon. But we had, some people say that's a small cohort. This was started back, my gosh, almost a half decade ago, and we're going to have a 3-year follow-up coming up. But there's some very important issues. First of all, this issue that I called attention to. As science evolves, and what was true before may not be true today. This looked at duplex Doppler as primary patency of less than 2. I think most of us would now use 2.4, some 2.5, and in the literature you're starting to creep in 3.0. We also look here, again, as the alternative. This trial did look into the future and actually prospectively, not post hoc, but prospectively looked at alternative endpoints along with the usual typical endpoints. Now look at this. Treated occlusions, look at these lesion lengths. These are not chip shots. These are not things that were dealt with in the Zilver PTX trial. These were long lesions. These were real-world patients comparing, again, a endoprosthesis stent graft versus bare metal stent. And again, we look at this one. Now, they went actually and chose the 2.5, but look at the patency rates based on duplex Doppler at 1 year. At 1 year. And now I'm going to suggest to you, do you think that this surrogate means anything? Does this mean anything to anybody? Does it mean anything to our patients? Because look at this. These slides are a little bit difficult, but it's looking at something that's important to our patients, which is their quality of life. And we looked at the claudication questionnaire and the SF-36. And these are 2 different scales. Best meaning 0, 100 meaning worst, and the converse on the other side. The bottom line is both of these technologies allowed at 1 year to have good outcomes with regards to patient-assessed function, and there was no significant treatment differences. Now look at this with regards to the surrogates. If you look at restenosis patterns, here's 2.0. Again, this is Gore-Viabon and bare metal stents, 2.0, 2.0 to 3.0, and greater than 3.0. And it was only after the 3.0 that these curves start to diverge. And similarly, on the other side, with regards to average ABI, the point here is the surrogates that we depend on as clinicians to compare apples to apples really mean nothing to the patients, I suspect, when it comes to what they want, which is to walk longer and walk further. Now, what is also important is, the patterns of restenosis that could somehow explain why this is. We saw that ABIs were different, and we understand that pressure drop versus flow rates in the patterns of restenosis between these 2 technologies may relate to how the patient feels. Now, I can tell you Gore has since disowned this data only because they've evolved now to 2 iterations beyond this stent graft that was used in this trial. But I can tell you that this is very important because to me, in a randomized prospective trial, it calls into question some of our design flaws that we have. Here's stent fractures. Look at stent fractures in over 15 centimeters in bare metal stents. It was, you can see here, almost 45%. Look at the grade of the stent fractures. Some of these were minor, but some of them were not inconsequential, and this becomes a safety issue for us. So some of the questions out of Vibrant that I think have to reverberate and resonate with all of us really deal with bare metal stents. Are they safe when we take them up greater than 15 centimeters? I understand a post-market surveillance trial by Bard is going to look at 17. They have a 25 centimeter stent in Europe. And do fractures are fractures a big deal? That's yet to be found out. Peak systolic velocity ratios are 2.4. Does that mean anything? And what about price? We haven't talked a lot about price, but we're going to in a little while. So the take-home messages out of this is really that in treating claudicants with long disease, it's safe. I was really concerned. I was part of this trial that we would turn chronic limb ischemia into acute limb ischemia because these stent grafts would be thrombosing. That wasn't the case. They restenose at their edge, and now hopefully Gore has taken care of that issue with their third and fourth generation stent grafts. We also understand that primary patencies were horrible in this trial, and it calls into the importance of surveillance of these patients. We must be proactive in maintaining assisted primary patency and reducing and getting away from occlusive disease, treating stenotic disease proactively. Again, surveillance is the issue. And again, stent fractures here, we don't know what they mean, but I think we're going to have a better sense. Most people would say we've gone now into second and third generations exclusively in the stent designs, and these become less of an issue. So we will present at Viva coming up in several months in Las Vegas the 3-year follow-up of this trial, so stay tuned and we'll have a better understanding in this randomized trial. I want to talk about metrics because I think this is what it's all about. You know, we talk about metrics in assessing the 2.0, 2.4, 2.5, 3.0. We talk about freedom from target vessel revascularization or target lesion revascularization. We talk about different time points. We talk about infrequently, we talk about therapeutic assessments, and I think that is something we really need to stop and start looking at, doing trials that look at patient-centric outcomes. You know, the whole thing is, you know, what does an ABI mean to the patient at rest? He's walking, he's a claudicant. We need to do these. We need to walk these patients to see how well they do. And really, what does a peak systolic velocity ratio mean? It's a poor surrogate for nothing. And obviously, the FDA will approve these stents based on these surrogates, but I can tell you what CMS did to carotid stenting and what CMS almost did to the renal stenting, they will do to this field if we don't get our act together as a bunch of doctors. Because it's a lot more complex when we deal with the pathophysiology of intermittent claudication. We have a supply and demand problem, no doubt, that gives us intermittent claudication and the functional impairment. But we also have a lot of biology that relates to denervation and atrophy and impaired muscle metabolism and reduced ATP production that really, despite taking care of the demand mismatch, persists, and we have problems in that regard. And so look at this. If we look after patients who've been revascularized and we look at their change in ABIs as opposed to their change in peak walking time, there is no difference. It's all over the place. So again, the point is the surrogates that we use in treating our patients and saying, I win, really may mean very, very little. So read this. AHRQ has already told us what they're going to do and what they're thinking. AHRQ has already told us via CMS is primarily interested in clinical outcomes in contraindication to what we really, you and I talk a lot about, which is vessel patency. So we need to move on beyond this. I want to go below the knee. I know Jason's going to talk a little bit about DES, but I want to reflect upon that in a similar fashion. These are all 3 trials that just were presented in Europe, looking at CLI, and you can see here what they looked at, which I think is, again, a waste of money, totally irrelevant. Looking at lesions less than 3 centimeters and looking at patency, and the question is, what does patency mean in a CLI patient? This is a typical trial. This is Achilles, randomized to balloon angioplasty. My point is here, look at this lesion lengths, 3 centimeters. Give me a break. I don't think I see 3 centimeter lesions in my CLI patients. It took them almost 40 years to do this trial just to find those lesions, only because they were held by the number of stents they had to use. Here's a success. Does anyone doubt that balloon angioplasty would do poorer than a stent? That's not telling us anything that we need to know. And here we go again with the improvement of drug-eluting stents versus bare metal angioplasty. Again, not a big surprise. So is anyone surprised that coronary DES is technically more successful than angioplasty, or that the binary patency rates are superior, or that somehow we have to get away from the fact that stent patency as a primary endpoint just doesn't cut it, and we need to talk about patient-centric endpoints again. So all these trials, what they did prove really is that, again, bad data. They were combining in CLI below the knee Rutherford class 2 and 3 patients. I don't know how they're doing that in CLI patients. And then they totally excluded Rutherford 6 patients. Again, to Dr. Martin's point, how can you do a CLI trial and exclude Rutherford 6 patients? And again, short lesions, those aren't things that we see. How generalizable is this type of data to the world that you and I live in? That's the key. Because here, I understand a lot of you out there are surgeons. Here's what surgeons understand, that graft patency is equated with successful outcomes, but it doesn't necessarily predict a favorable long-term result. Here's an interesting study done in Rutherford patients greater than 3, and they define clinical success as having all 4 of these: graft patency to the point of wound healing, limb salvage. Patient had to be ambulatory at 1 year and had to live at least 6 months. And if you take all of those and you follow them prospectively over 3 years, only 44% of those patients, have this clinical success. So it really means very little to say, hey, your stent is patent, but you've lost your leg. We need to look better and do more. So what I think what we need to understand is how clinically relevant is 6 to 12-month vessel patency, and how does that relate to limb preservation, pain control, and the maintenance of function and mobility. Those are the things that I think CMS is going to want to know before they pay a lot of money for this, and something that we don't do a lot of and talk a lot about is wound healing. So we need to move beyond below the knee, the coronary paradigm. I want to talk real briefly about the Excel trial. This was a Viva trial that looked at 120 patients, and we looked at some very detailed data through 3 core labs, and basically noted that amputation-free survival was approximately 78% at a year. But if we pull apart the patients who died, and we looked at the Rutherford class, you see here that a lot of these patients are dying from processes unrelated to their procedure. If you look at a better endpoint, which is limb salvage, 55 in Rutherford 6 now becomes 70. And again, I think this is a better way of assessing these patients. We understand that not all wounds heal for a multiplicity of reasons, and we need to understand that, at least in this trial, we had wound healing rates that were comparable to surgical wound healing rates, and actually we had time to wound healing that was superior. And the question is, why don't all wounds heal? The simple fact is because we don't pay attention to the angiosomes. We deal here the angiosomes, and we many times do not treat the wound-related artery, and therefore we cannot expect that wounds will heal. Here's the perineal angiosome. Here are the foot angiosomes. And this is where I think industry can help us with better techniques and better technology, so we can go after that angiosome-related artery, heal those wounds, and preserve those extremities, go into the foot. Here's one piece of data from Japan that shows that if you deal with the wound-related artery as opposed to not dealing with it, your limb salvage rate out to 2 years is superior. So take-home message is that at last, we have some data to talk about, and the data will be continuing to come. We need, however, to challenge ourselves and industry and the FDA to look at more patient-centric data. And CMS, unfortunately, I believe, is going to have a last word in a lot of the things that we do, because they may not pay for it unless we start doing this. Thank you for your time.
and products and techniques that are needed for successful interventions for critical limb ischemia. Talk about vascular access, talk a little bit about interventional sheaths, guide wires, and crossing devices dealing with vessel occlusions. I do have some consultant and research support relationships, but none that are directly related to the topic today. First, let's talk about access. First of all, any procedure, any intervention starts with vascular access, and the consequences of an imprecise access are usually nil. Femoral artery thrombosis can occur, pseudoaneurysms or groin hematomas may happen, and occasionally there's a large groin or retroperitoneal hematoma. So usually it's not a big deal, but sometimes it can be a big deal. So what do you do to minimize the morbidity of the approach and to maximize the success of the procedure? Well, one of the things that we've adopted for many of the procedures in our lab, all of the ones that I do, is ultrasound-guided access. Safe vascular access can be achieved without imaging, and that's the way I learned it, but with imaging, you can reduce the risk of vascular injury because you can more precisely enter the vessel in an area that's not diseased. Guide wire that comes with the set doesn't have the stiffness to support passage through densely scarred tissue, so sometimes a larger needle and 035 system is useful. By doing the setup on a routine basis, you don't have to worry about answering the question, do I want to use ultrasound this time? It's a real hassle if you start and have trouble and then say, okay, now I'm going to use the ultrasound. If you always have it, it's always set up, it doesn't add any time to the procedure, and you and your trainees gain the experience of getting that mental picture of what the vessels look like with ultrasound, and it goes quite quickly. In general, it's a freehand technique. The non-dominant hand will hold that sheath transducer. The dominant hand will hold the needle and advance it, and then the needle is stabilized once the vessel is entered and the tip is centered. Now, there are other devices that some people use, and the needle guides that are available for some systems helps to keep a needle in a scan plane. I think it's a little harder to use, quite frankly, than a freehand technique once you get that 3D picture in your brain. And there's some other products coming out. Introduce the next speaker. The next speaker is Dr. David L. Dawson from the University of California, Davis. He is a professor in the Department of Surgery, and he's going to talk to you about lesion crossing access and specialty wires. Some people would call this a Coles to Newcastle talk because it's addressing a group of experienced vascular specialists. But the group, as I told you this morning, is somewhat of a heterogeneous group. We have surgeons, radiologists, cardiologists, and others here, and not everybody does everything. I'm going to talk a little bit from the perspective of someone whose practice includes a large volume of critical limb ischemia work, and talk about a few things that we've learned along the way, a few things that we've adopted, and not get into any attempt to compare some of these different apples that are out there, but to give you a little bit of an overview of the types of device needle to enter the vessel. I'll be able to visualize the inguinal ligament, visualize the profunda origin, visualize plaque in the common femoral artery segment. The other technique is to infiltrate anesthesia under ultrasound guidance, because you can put the anesthetic right in that periarterial plane. I watch some people infiltrate, and they'll put a large volume of anesthetic into the subcutaneous tissue where the nerves don't live. And the patient then says, ouch, when the sheath goes into the artery where the nerves do live. So it's actually a nice technique for more precise local anesthesia. Introduce the needle in that longitudinal plane and then turn transverse to then do the fine tuning to center the needle to puncture the vessel in the center line. And then the ultrasound can confirm the intraluminal placement of the guide wire. I like to use the micropuncture technique with a 5 or 4 French micropuncture catheter, a 21 gauge thin wall needle. You can use an echogenic needle or an echotip needle to help improve visualization with ultrasound. And the micropuncture technique is especially useful when you're doing brachial access or superficial vein access. It is less effective when accessing through dense scar because the 18 thousandths, you can recognize the variant anatomy. You can find that high origin of a profundifemoris artery. You can see where the graft origin is. Whatever the situation may be, you'll have that situational awareness. And you can obtain access in pulseless arteries, which is often the challenge in treating patients who have lower extremity peripheral artery disease. Ultrasound-guided access reduces the risk of hematoma or vessel injury because if you get in accurately and precisely the first time and you don't get any hematoma, you're more likely to get good primary hemostasis. It improves the results with vessel closure. If you're using a suture-mediated device and the needles have to pass through the vessel wall, if they pass through a relatively undiseased segment of vessel wall, you'll be more successful. If you use a device off-label for pre-close, for large vessel closure, such as we do for percutaneous aortic aneurysm repair, ultrasound-guided access allows precise placement of those closing sutures, and you can avoid damage to important and expensive adjacent structures. The technique is to sheath a transducer in a sterile sheath with gel in it. I tend to image the vessel in the longitudinal plane. I'll find out how far north or south I want that needle